Okay. There, I'm letting everyone in. Good morning, everyone. Welcome to our session here with Rhonda Spellmeyer from KONZA Health. She's going to show us some of the new tools that they have revamped and some of the old tools that still exist to help us utilize their tool for just health information exchange and closing care gaps. So with that, I'll hand it over to Rhonda.
Awesome. Thank you so much, Terry, and everyone for joining us. I'm going to share my screen, but before I do, just want to point out that I will go through the presentation and then I will open for questions at the end. And Terry will have the slide deck available for the attendees. And so I will be turning off my video just to provide less distraction here. So I'm going to do that and we'll go ahead and start.
And feel free to use the chat to put
Yeah.
in questions if you have any.
Okay. Are you guys seeing my deck?
No.
Okay. Now hold on a second. I need to share a different different screen. Um, there we go. Okay. I think that's it. You should be seeing it now.
We see a PowerPoint presentation.
That
Well,
is exactly
one of the
what you
slides.
need to. Yeah, you see a slide. Okay, let's see. My apologies. Here we go. There we go. Are we good?
Yep.
Awesome. Okay, so we're just going to talk about how to optimize the use of health information exchange data. Um, today to help support your organization and its operations. And so this is our quick agenda. I'm just going to talk about KONZA Health, especially for those on the call who may not be totally familiar with us or maybe remember our previous name, which was Kansas Health Information Network. We're going to talk about what interoperability is and why you should care about it. And a lot of that is really to kind of get everybody up to speed. Not everybody is aware of what exactly interoperability is and what kind of influence it could have over the care you provide. And then we're going to talk about the tools that we have available for our organizations, many of whom are you, and you're already part of our our network. And so we just want to make sure you're aware of what is available to you. And then we will open things up for questions. So, first off, the just to give you an idea of our growth, because not everybody understands interoperability, where it started, how it's evolved. I won't go through all of the fun policy updates, but essentially we were established in 2010 as the Kansas Health Information Network, and that was in a direct response to the American Recovery and Reinvestment Act of 2008, which held the Health IT or Health IT Act or High Tech Act, which kind of was the catalyst for requiring organizations who bill Medicare or Medicaid to utilize electronic health records. And along with that came the basis for our foundation of interoperability. So a few years later, we became a national network when we expanded across state lines. So kind of moved out of Kansas into Missouri. We are also I think we're in 12 states total as a health information exchange. And then we, in 2023, became a QHIN under TEFCN. I'm going to talk a little bit more about that because I think it's really important to understand how policy absolutely does affect your technology and how you're utilizing that technology at your organizations. And then we rebranded as KONZA Health because we are truly a nationwide health information exchange, but we are also still a regional health information exchange, especially in Kansas and Missouri. So just to kind of highlight that's been our growth. With that being said, I do like to talk about what interoperability is. You know, I think something that we kind of forget is or not think about is all of those pieces and parts that work together. You have an electronic health record, but how often do you give thought to how that information leaves your EHR or even how it comes in? So, obviously, I'm not going to read the definition verbatim, but the HIMSS organization, and if you happen to be involved in any part of your EHR technology or in health information management, you know what HIMSS is. But it's really the ability of different systems and devices and applications to access and exchange and integrate and utilize data in a coordinated manner. It all sounds really good on paper. I think we've thought about, oh yes, this can communicate with this. We have an interface for that. I can think of you probably like, for example, at my local clinic, we utilize a system now that lets us register ahead of time, and that system interfaces with the EHR that my local clinic uses. That is interoperability. We also have, when you think about billing and you think about when you are dropping claims, when you are submitting, quality information. All of that relies on interoperability. It relies on the system that you have to be able to communicate with other systems. Thinking about public health, when y'all are sending immunizations to WebIZ or receiving those immunizations or retrieving them back into your EHR from WebIZ. So it's really not just about faxing a medical record somewhere. This is about systems sending and receiving data across a whole entire network of different systems and different actors within the healthcare continuum. I do like to point out here that Kansas supports interoperability as an opt-out consent state. So what does that mean for you? Kansas is kind of unique, and Missouri also follows suit with this, in that the legislation supports the sending of data automatically to accredited HIEs in Kansas. We're accredited by Kansas Department of Health and Environment without patient's consent, without express consent. So what that means is you don't have to get consent every time your patient comes in for you to send data to an accredited HIE in the state of Kansas. There's four. KONZA is one, and we happen to be probably the largest as far as connections. But what that means is it kind of removes that bottleneck. Now, patients can go and choose to opt out. They can go to the website and opt out. They can, learn more about what this means. Usually, you would have this information available to your patients. And if you have questions about how to notify your patients that they're being sent, or that their data may be sent to the accredited HIE, let me know. Most organizations, when we onboard them, get that included in their informed consent or their general consent, just that it's being sent. And then there is also their brochures and signage that we can provide to have at registration so patients are aware. So something that is kind of new in this space, I feel like everything's always kind of new, but for anybody who's a policy nerd like I am, you may be aware of the 21st Century Cures Act, which was legislation that came through a few years ago that really helped to establish a national network of networks. So if you um, think about all of these different health information exchanges, the idea behind this is that the federal government says, instead of forcing organizations to have integrations with all these different HIEs and different payers and different government entities, why don't we have them connect to a participant who participates in a QHIN? And so the QHIN is essentially I think there's 12 of us now. And so if you connect with one QHIN, the QHINs actually then can talk to each other so that you don't have to have all of these different connections. That is the premise behind this. Of course, there's a lot that goes into that, and that is where the Trusted Exchange Framework and Common Agreement comes in. And I will talk about, don't worry about what this means for you. But essentially, what we've done, or what the federal government has done, is said, listen, we need a set of rules, and we need, for policy and operating procedures. And then we also need a, a blueprint of how this framework should work from a technical perspective. Because how often have you seen, well, this doesn't talk to that, or they're sending this data, but our system can't read it. So really working through how to create a network where we're all playing by similar or the same rules, and utilizing um, or utilizing technology that works together. It doesn't mean it has to be the same technology. It just has to be able to work together. So keeping in mind, KONZA is a QHIN. We spent a year working on being recognized and applying for and getting that designation. And then your organization, your FQHC, is a participant. So most of you, I believe all of you, are part of our QHIN. So that means you're a participant. You send data to us. You're also part of our health information exchange. And so when you're part of the QHIN, then let's say one of your patients goes to, across um, the into Nebraska, or especially if your clinic is near a border, then your data could then be available to another participant if they're also a member of a QHIN. And I believe we're upwards of over 70,000 participants now. Just keeps growing. Millions of documents have been shared and exchanged in the last 2 years that this has been live. Why does this matter to you? Now, what I think is unique is that you have, especially if you're in Kansas or in Missouri, you have a lot of regional connectivity, which means that organizations in your area are usually connected to the regional HIE, which is KONZA Health. But we know patients travel. Patients, they might be folks who follow jobs. They might be folks who, for one reason or another, are moving about. And in that case, that's where you can have that. You have access to that nationwide connectivity. So it really does, because you are participants for us, it really does help you have access to national data. Now, are you going to need that data every day? You don't necessarily have to have nationwide connectivity, but it sure does help when you have a patient who comes in and maybe they're new to the area and they've come here from another state. I've actually seen that, which is just incredible. I had a patient, or a site, who had a patient that they see in Emporia, and they actually received an alert that they were in an emergency room in Mississippi. And when we kind of looked through that, we thought maybe it was a mistake. Nope, the patient was visiting family in Mississippi and ended up in the emergency room. So once they came back to Emporia, they were able to get their follow-up, and the site in Emporia was able to have that those records. So just keeping that in perspective is that not only do you have regional connectivity, but as a member of the KONZA Health QHIN, you do have access to national data. And we'll talk a little bit more how you're going to get that access when we talk about the tools that we have. Now, I do want to mention that one of the goals of all of this, and again, interoperability always has to start somewhere. And, it started back in 2010, got a lot more robust, and now we're, expanding that out. We're not just expanding the connectivity across broader networks, but we're also going to be including some other options, not just sharing records from a clinician to a clinician, but the goal is that public health reporting could potentially be done through QHINs, government benefit determinations for disability, instead of having to request all of these different records manually, that we would be able to, the government disability determination could be more efficient by obtaining these records through QHIN connectivity. It also can help, simplify, or I shouldn't, don't want to say simplify, but we can have, more efficient public health response in times of pandemics or epidemics. Thinking about, for example, the big soccer, event coming up in Kansas City, and that we're going to have a lot of folks in Kansas City who are not from Kansas City, and how this could help, help support not necessarily an emergency or a disaster, but just an influx of patients that um, are not from the area. So just thinking about how this is still in its growth period, but right now you do have access to a lot more records than you used to from organizations that historically you may not have had access to. Why should you care about interoperability? I won't go down too far down a rabbit hole, but I like to think of things, especially as a former CNO, from a clinical, operational, and financial standpoint, because when we do things, obviously patients come first. We want good patient outcomes, and we want patients to have a happy experience and not, come in for their visit and we don't have the records we need to provide them the best care possible. So thinking about from the clinical perspective, improve care transitions and improve care collaborations with other providers because you have their records and they should have your records because you contribute data. Reducing unnecessary duplicative testing. That has a financial component, but also nobody wants to have their blood drawn more than they need to. We also don't want to expose folks to radiation more than we need to. So if they just recently had a CT scan, then let's obtain that versus repeating it. Quicker access to outside records when you're seeing a patient, and not saying, well, shoot, you're here now, but I don't know what discharge meds you were sent home on from the ER. And that kind of leads into access of just relevant clinical information so that you can make better care decisions, especially for populations with fragmented care patterns. I think, and that can be just anybody at this point, because, I think about our patients that, even my own family members that have specialists in Kansas City or Topeka or Manhattan, and being able to, ensure that their care is focused on the whole person and not just the data that's sitting in front of you. And then we want to improve patient and clinician satisfaction. I think, with EHRs, we talk about burdens and how much that has sometimes really frustrated clinicians. I think that interoperability is one of those tools that can actually reduce frustration by having the tools that clinician needs to help give their patient good care. And then one that we don't think about a lot is access to records during EHR downtimes. That's a newer use case that we've been exploring because we do have a web-based portal that, as long as you have internet and you have the ability to receive your MFA code, if your EHR is down for whatever reason, you can even see your own records because you've been sending them to us. Thinking about operational, just basically, one of the biggest things I think of is that collaboration with other healthcare providers. If you think about our community mental health centers, a lot of them are accredited now as CCBHCs. And that requires them to collaborate more with the medical care providers. So I know as FQHCs, you really do a lot of collaborating. You're very unique in the fact that you have to work with everyone. So this can help smooth those operations. It also gives you alerting tools for admissions and discharges. You don't have to wait for those hospitals to let you know manually that a patient has been at their facility. We can reduce requests for external records, which helps to just free up time for other things. There's nothing worse than having a full-time person who's just requesting records all the time and then eternally waiting for them to be faxed. When we think about financial, and there's some really cool studies that go into this, but we do see a reduction of Medicare and Medicaid spending per beneficiary. And that is so important, especially as we move into these value-based payment models. That we want to reduce spending while improving quality of care, and interoperability can help support that. thinking also in Kansas, we do have the QBRP incentive program through Blue Cross Blue Shield of Kansas. So there, I believe that's up to 3% um, uh, incentive payments for your claims if you're sending data to the accredited HIEs in Kansas. So that right there is a great incentive because that's just money back in your funds to provide and allocate to other resources and things that that you find would be a priority. We also can see improved revenue from care transition, follow-up, and care coordination, and then Medicaid alignment. A lot of what we're seeing with Medicaid is really wanting um, to support interoperability. And if you have questions about that, I'm happy to give you some information about what that looks like. But we're seeing Medicaid really, even though with Medicaid and FQHCs, you're not necessarily required to share under promoting interoperability anymore. A lot of the initiatives through Medicaid are really leaning toward interoperability support. So when we think about the tools and services, and this is kind of the bread and butter of what I think we wanted to talk about today. And obviously we have a lot of tools and services that are available to you. And I won't be able to go into the greatest detail, but what I want you to take away today is an understanding that you have things available to you and that you have initiatives that these tools can help support. So I want you to walk away with your wheels spinning about what you can do and what you can use to help support these initiatives. So some things to think about. One is you all would have access to Gateway Plus. That is our web-based portal that's available for all of our qualified health information network participants. So that is where you log in, and I'll show you shortly. We used to call it Caroline. It still is Caroline, but Gateway Plus is for our QHIN folks. That is where you can see or gain access to not just the regional HIE information, but also to other qualified health information networks. We also have direct secure messaging available there, but most of you probably have that available within your EHRs. And so that may not be a tool that you would utilize as much. But Gateway Plus is just that login, search for a patient, and pull back information and get what you need. The second way you can access information is within your EHR. So most of you have what we call a bidirectional interface with KONZA Health, which means you send us data, and we very much appreciate that because other participants like to see your data because they share patients with you. But you can also retrieve data into your EHR. And there are workflows where that is ideal. So what we try to do is support both workflows or multiple workflows, the ones that happen within your EHR and the ones that maybe need to happen through our web-based portal. Within your EHR, you query just the same as with our portal in that you can get regional HIE information, but you can also get qualified health information exchange networks information as well. And then we have our special tools, and we're going to talk about these a little bit more on the next slides. But these are those tools that kind of take interoperability to the next level. One is our acute alerts for care transitions. We're going to talk a little bit more about that on another slide. Then we have kind of our leveled up alerts. These are called rapid alerts. We'll talk a little bit more about those. And they have two new products that I am super excited about because I think they are something that you can really appreciate and utilize. We've done some revamping of our HQ Insights analytics tool because we recognized that it was not exactly the most user-friendly and some of the tiles weren't being used as often. So we'll talk a little bit more about a quality measure optimizer elite, just call that QMOE. And then we're going to talk about Birth Connect, which is probably the one that's near and dear to my heart because it is intended to improve maternal health mortality or improve maternal health and reduce mortality and morbidity. So Gateway Plus. Obviously, I'm not going to do a full training here today, but and we'll talk a little bit more about how you can get more training. I've got the URL here, but this is just nothing more than a website that you can access. You log in, you search for an individual patient, and this is where you can retrieve local and national data via our HIE and our QHIN connections. This is where you can see records for individual encounters, so like a continuity of care document. Um, I just was working with an organization where, they were struggling to find some information for patients that are being seen in the emergency room. We found what they needed on these CCDs. Not everybody knows what a CCD is, but essentially when you finish an encounter, the EHR will create a summary of that encounter. And so it bare minimum, meds, allergies, problems, procedures, but typically you'll see labs, you can see radiology reports, you can see immunizations, you can see what they did. Maybe, and a lot of times we're even seeing notes, and I'm seeing a lot more screenings like PHQ-9s, PHQ-2s. I've seen some Vanderbilt. I've seen, some wonderful screening tools. Especially as we move forward with EHRs being required to have USCDI version 3, but that's for another webinar. But essentially, the continuity of care documents are what most folks will look at initially, and then we also have, depending on the organizations and what they've chosen to send, you can see a progress note, discharge summary. The discharge summaries are one of my favorites. A lab report, okay, so maybe you've got a patient that's on an anticoagulant. So you need that PT-INR that they had done, a month ago, so you can do some comparisons. So there's some really great information to help you either through these continuity care reports or the individual continuity of care documents or the individual reports. We also can include or do include longitudinal records. So maybe you just have a brand new patient that you just need their history and you want it on one record. We provide that as well in our consolidated CDA that gives you a 12-month look back of all those individual visits. That's also what you'll see generally through the QHIN records too. I've seen some really great records from organizations in Missouri, in Arkansas. I've seen, all over the nation that are coming through via the QHIN. What's also really handy is that you can export the documents. You can print them to paper if you need to and scan them or utilize them however your facility's policies allow. But you can also export it to a PDF, save it. So if you're doing a lot of care gap closure, you can come in, get all your records for all your different patients, save them to a secure network folder, and then you can work from there. So you don't necessarily have to stay logged in to the web-based portal. And then again, organizations that have bidirectional interfaces can access KONZA Health records within their EHR. That workflow is going to be very dependent upon your EHR, how you've configured things, and what your individual policies and processes dictate. So if you're ever, want to learn more about how that works within your EHR, I'm happy to help you with that. Again, a lot of it just comes back to how you're wanting to utilizing, if you're wanting to reconcile information, if you're wanting to pull in data for your provider before a patient visit. The alerting tools, I think, are probably some of the most useful information, especially when we're talking about care transitions. And I know our FQHCs really have to follow up with these care transitions, especially for your quality work and just overall making sure your patients are getting the care they need, keep them out of the ER, and ensuring that they are able to follow up with everything that's needed, especially after an ER visit or an inpatient or observation admission. The tool that you guys all have access to through your standard participation agreement with us is the acute alerts. That lives within the HU Insights Analytics dashboard. That is a separate website from Gateway Plus. So those are two separate websites with two different types of uses. What happens in the acute alerts is you get a running list of your patients that are attributed to your organization, and it lets you know in near real time that that patient has been admitted to the ER, that that patient was admitted and discharged from an inpatient stay. This is just a snippet of what that looks like, but you also get who sent that information so you know where they were. And you'll know also whether either their reason for their visit or the diagnosis, there can be their PCP. There's just a lot of information that can be available there. And then if you still need more, you can look them up in Gateway Plus and find out, what meds were they sent home on. Did they have some kind of screening that I would want to have in my records? Something that we are going to be adding to this tool is our suicide risk assessment that's coming, where we developed with I believe it was the University of Connecticut, to identify patients who may be at higher risk um, for um, for that kind of activity. So once that goes live, we will announce that to our end users, and you'll be able to see if if a patient potentially could utilize some intervention. This list is also exportable, so you can export it and work from that, not have to stay in the dashboard to utilize it. Um, and then again, it's in near real time. I think we've timed some of these, and the alerts will come through and be parsed to this and within about 20 to 30 minutes of an admission or of a registration. So that tool is available to you all. And if you need assistance with how to use that, or if you even want to know if you have access to it, feel free to reach out to me. My email is in the presentation. The other alerting tools that we have available to you now are the Rapid Alerts Direct, or that could be available to you, and Birth Connect. So Rapid Alerts Direct just takes this alerting a step further. It does require more build and a contract and payment, but it delivers the alert that would normally land on the acute alerts list. It actually delivers the alert to your direct message inbox. So for those organizations with EHRs that have direct secure messaging, which is pretty much everybody, you would just get a message in your inbox that says, hey, so and so was admitted, and then so and so is discharged, so that you don't have to actually leave your system to know that these patients have been seen somewhere. So that is a really neat tool. And again, if you don't have direct messaging in your EHR, you don't want to use it there, we do provide direct messaging in our web-based portal. And then our Birth Connect alerting tool, this is brand new. We piloted it in Connecticut. But this is also can be located within the HQ Insights Analytics dashboard, and it is an additional functionality that would require, contract and funding. But this lets you know when an attributed birthing patient delivers, and then also cross-references the infant information in near real time. So this lets you know babe was born, this is the date, the time, where they discharged home, were they admitted to a NICU, what was their birth weight. So there's actually quite a bit of quality information that we can get through these as well. I love this one because I think it's great for ensuring that the birthing patient gets seen and gets their follow-up, and that the infant gets their follow-up as well. And then additional tools and services that you all have, and I mentioned QM Optimizer Elite. This is also available within the HQ Insights Analytics dashboard, and this is a very unique tool because it combines claims and clinical data to calculate NCQA accredited measures, quality measures. This allows you to identify and close care gaps before you have to do all of your reporting. So what I like is that in my history, we didn't always know how we were doing until we submitted everything and then, found out from our payer or from Medicare what our clinical measures looked like. This actually utilizes the claims and clinical data, and not just clinical data that's yours, but maybe your patient had their colonoscopy somewhere else, or you need to see that they met that measure, or they haven't met that measure, so maybe you need to do some outreach to them and close that care gap. This is a really exciting tool, and it's all based off of NCQA accredited measures. We've worked with them. This was actually, we were one of their pilot organizations to do this. It does require more build, and it's an additional functionality, but this is something your organizations can use to identify um, more accurately where your care gaps are and then get them closed. And then identifying those trends, et cetera, and having more opportunity to address those in your real time. And then the other tool that we have, and some of you we may have touched base with you and reached out about this, but all of our organizations that provide data to us are given the opportunity, or are evaluated for data quality. So I'm sure most of you have heard garbage in, garbage out. We want to make sure we aren't getting garbage in. So we ensure high quality data streams. This means we do our own internal PSV, primary source verification audits. And what that does is it can actually allow for an exemption from HEDIS PSV audits. And some of you may or may not know what I'm talking about, but essentially when you're submitting, payers have to also measure the quality of care that you're providing to their insured. And a lot of times that includes them having to come and get clinical information from an organization, and it's quite burdensome. What we are working to do is to deliver your clinical information to the payer without you having to manually submit it. This is information we're already receiving. So we work to ensure that the coding is correct, that the information that's coming to us makes sense, and that it accurately reflects the care that you've given. And when that happens, it can enhance your HEDIS scores, which then can enhance your payer contracts. I've been working with some organizations out in Connecticut on improving their depression screen HEDIS scores. And what basically we're finding is they're doing the screens. It's just not making it from their EHR to their payers electronically. And so we've been working on improving their EHR builds and looking at some of their work streams or their workflows to ensure that they are getting the credit for the work that they are doing. So that's a really exciting program. We have, I believe we have the largest accredited and validated data stream of all the validated aggregators. And this is just a little tool for you guys to take back and discuss internally. But I think one of the biggest challenges with interoperability is how do we implement it and how do we sustain it? Because it's not something you think about every day. It definitely affects your end users, it affects patients, but it's kind of behind the scenes. So these are just some steps that I put together that I utilized in my practice when I was a CNO, but also that I have recommended. A lot of what you're doing, you've already planned. Planning for implementing HIE has happened, but you may need to go back and reevaluate that plan annually as part of your strategic plan. What do we have? How does it support what we're doing? How does it support things we want to do? Implementing, most of you have implemented at some point, but maybe your implementation has kind of fallen by the wayside. And a lot of that is usually related to staff turnover and not necessarily writing or including interoperability into your standard operating procedures. And so I would challenge anybody on the call to go back to your organization and identify who your client administrator is for KONZA or KHIN, because that's the person that gets you guys your user logins for our portal. So that's just one takeaway from this. I would challenge you to go back and say, oh, who's our client administrator? And if you don't know, reach out to me and we'll get you going, and we'll let you know who your client admin is. And then with maintaining, that's something that we also, just think of this as a non-ending, PDSA cycle. We are doing quality improvement and quality assurance. So making sure that you continue to review the use, and we can do that through auditing. As I mentioned before, reviewing annually as part of your strategic plan. Getting feedback from your end users. We love feedback, even if it's not always fun feedback. I love hearing from customers or end users, hey, I really could use this. Where is this at? And then finding, hey, maybe there's an opportunity for us to improve some data that we're being sent or not sent so that, this particular end user gets what they need so their patients have better care. And with that being said, these are some resource links that I put in here that just kind of help give you more information about the things I talked about, because I know that was a lot of information. And then we're going to open it up for questions now.
All right, we did have Tara asked for the link to the HQ Insights analytic dashboard. I actually wasn't able to find a link, but I did put a link in to the information about HQ Insights. So I don't know if that's something that's on.
Yeah, the link is actually on our homepage up in the right-hand corner. On the let me look here and see if I've got it. Yeah, I believe that yes, if you go to home KONZA National Network and go up into the upper right-hand corner of the window, that's where the link is to HQ Insights, to the login.
So I think the link that I put in there is you can get it from there. And then Tricia asked, how are attributed patients identified? Do payers provide that information, or do clinics provide their attribution lists?
So the attribution, it depends. Essentially, we do not get the attribution list from the payer. Typically, organizations that send us data also send us their registrations. And so we have a couple ways we can attribute patients. One is through an automated attribution process, which involves your registration. So we would attribute a patient to you. If they've been registered at your facility within the last 18 months, that can also be tightened to 12 months, or even 6 months. It's really, we can tailor that. The other way is, and some organizations, even if they are contributing data to us, they could actually just submit a patient panel. We have organizations that will update a patient panel once a month to, add patients in that maybe you have a smaller population that you're really focused on for alerts. You can say, these are the patients we just want this list of folks, and you can update that. Some folks even update them every couple of weeks. So those are the two ways that the attribution happens, but they are going to be customer specific, but not payer specific. If you want us to do payer specific, that is possible, but that would be initiated from you.
Okay, thanks. There are no more questions. The only thing that I would like to ask is for everyone who's on this session to complete the evaluation. I put that link in the chat. So does anybody have anything else before we let Rhonda get back to her regular day?
Terry, it's Maria. Rhonda, one, I'm very excited about the birth records thing. That was always a huge, when I
Yeah.
was at the clinic level, it was huge because nobody knew how they name the naming conventions
Yep.
and everything else. So amazing. But I wanted to make sure that everybody on the call knew that, especially with eClinicalWorks, they are pushing their QHIN. If you are already have a bidirectional or even a unidirectional interface with KONZA, you are already, you could possibly already be with KONZA's QHIN. You don't need to go with ECW. You can say no to ECW. I'm not quite sure how NextGen and Athena are doing it, but ECW is pushing hard. You have to make a decision by the end of March. And if you don't tell them, they're going to just automatically, I think, try to hook you up to theirs. So I just wanted to
Yeah.
make sure everybody's aware of that.
Thank you so much, Maria, for mentioning that. So one of the things with the QHIN, and that is where this gets challenging, and I feel for our customers because it can be very confusing. We had set out when we became a QHIN, we sent everybody basically a notification that we were going to put you in our QHIN because we were a QHIN before ECW and the other EHRs. That we would, put you into our QHIN unless we heard differently from you. And that's what ECW is doing. Now, there is a vetting process. So when ECW goes to vet your organization, we would have to block that. I mean, ideally, you would just go ahead and respond to them and say, no, thank you. I'm already a member of a QHIN because they're not checking to see if you're already a member of a QHIN before they attempt to vet you. And I know that vetting sounds painful because it is, but we would look at that and go, oh, no, 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 community care, or Hunter Health, you guys they're already members of our QHIN, so no, unless they want to change QHINs because you can only be a member of one QHIN. And you're already connected to us. You already have that regional data, which is kind of a nice thing. Because that regional data is not always going to be as available in the QHIN as it is with the HIE. But Maria, thank you for bringing that up. And if you have questions about that, please shoot me an email and we'll help you navigate that.
Okay, looks like we don't have any more questions. So thank you all for joining. And thank you so much, Rhonda, for a great presentation.
Yep, thank you. And again, please reach out to me if you have questions or if you want more training. We are getting ready to schedule our monthly lunch and learns again. We took a little bit of a break, and I'm updating user guides. So be on the lookout for some exciting invitations for our lunch and learns.
Thanks, everyone. Have a good day.
Thank you.
Thank you.